Hello everybody, my name is Austin Pates. I'm a PGY1 acute care pharmacy resident at Cone Health. Today we're going to be talking about sexually transmitted infections. As we go through today's PowerPoint, a lot of the information can be found in the CDC STI guidelines that are regularly updated. This is a good reference for future practice, as much of this information changes over time based on different resistance patterns and new information as it becomes available. After this presentation, you should be able to talk about background information on sexually transmitted infections, identify common sexually transmitted infections, and review treatment strategies for sexually transmitted infections. To provide a little background on sexually transmitted infections, there is a higher reported incidence in men, but more frequent and severe in women. 2/3 of STIs occur in teens and in the people in the age of 20s. Increased age equals decreased incidence. The single greatest risk factor is the number of sexual partners, and rates are disproportionately high in men who have sex with men populations, or MSM, compared to heterosexual populations, usually due to the fact that many people in these populations don't believe that protection is necessary. Prostitution and illicit drug use also increase the incidence of sexually transmitted infections. The first sexually transmitted infection that we'll be talking about specifically today is chlamydia. This graphic shows chlamydia rates by state in the United States and in outlying areas from 2017. The prevalence of chlamydia in the US is about 1.5%. And with that, the prevalence is highest in the patient aged 24 or younger. Women who have aged 15 to 24 have the highest rates of chlamydia in the United States. Chlamydia trachomatis is a small gram-negative bacterium and is the most common cause of bacterial sexually transmitted infections in both men and women. In the United States, it is most commonly reported nationally notifiable disease. A significant portion of patients are asymptomatic, thereby providing an ongoing reservoir for infection. The most frequent clinical manifestation of chlamydial infection in men is urethritis, while the most common finding in women is cervicitis. It is associated with an increased risk of HIV, and it is very difficult to identify as it can't be seen on a gram stain as it is an atypical organism. Gonorrhea can be distinguished from chlamydia as gonorrhea is associated with a more purulent discharge, while chlamydia has a urethral discharge that is less profuse and more mucoid or watery than gonorrhea. Chlamydia has an incubation period of approximately 35 days. Most common sites of infection are the urethra and the endocervical canal. Symptoms may include dysuria, discharge, and pain with sexual activity. 75% of females and 50% of males remain asymptomatic, providing an opportunity for further transmission. Symptom onset typically occurs 7 to 21 days after exposure. CDC recommends screening in sexually active females less than 25 years old and older females at high risk, particularly those who have multiple sexual partners, or those reporting their sex partner may have a concurrent sexual partner. Chlamydia screening in men should only be considered when resources permit. Prevalence is high, and it does not hinder chlamydia screening efforts in women. Complications in men may include epididymitis, and in women, complications may include pelvic inflammatory disease, which may lead to infertility and long-term reproductive complications. This slide provides a bit of a recap on who should have regular screening for chlamydia. Women less than the age of 25 should be ideally screened annually. Women aged greater than 25 only require routine screening if they have select risk factors, including multiple sexual partners, or a sexual partner who also has a concurrent sexual partner of unknown activity. Men who have sex with women are not routinely recommended to obtain chlamydia screening. Men who have sex with men, it's recommended to have annual screening for chlamydia. It is also recommended in the HIV population to have annual and more frequent screening if indicated. The first-line treatment option for the management of chlamydia is doxycycline 100 milligrams by mouth twice a day for 7 days. Alternatives include levofloxacin once daily for 7 days, ofloxacin twice a day for 7 days, and azithromycin 1 gram by mouth one time. And an advantage of azithromycin is that it may be used in pregnant patients. It also has excellent intracellular and tissue penetration, and due to its half-life of 5 to 7 days, azithromycin can be administered as a single dose of therapy. It can also be used in pregnant women, and providing single dose of azithromycin on site at the time of diagnosis helps to ensure compliance. However, due to increasing rates of resistance, doxycycline remains the standard of care. Some non-pharmacological things that should be considered for chlamydial infection treatment and overall management is to abstain from sexual activity for 7 days following treatment to prevent future transmission to sexual partners. It's also important to collect sexual exposure history for the last 60 days and identify other possibly infected people and notify them that they may have become infected so that they can receive treatment. It is also advisable to abstain from sex until all other sexual partners have been treated. To maximize adherence with recommended therapies, medication should be given on site, and the first dose should be directly observed if possible. If you happen to get an STI, you're more likely to get another, so follow-up is recommended. Expedited partner therapy is also available in North Carolina, which just means that if you have a sexual partner who may have chlamydia, you could potentially provide that person with a treatment regimen of doxycycline without having seen them in clinic. Something that's important to be aware of for all of these sexually transmitted infections is whether or not a test of cure is indicated. Meaning, after treatment, do they have to follow up back with you in clinic to make sure that their infection has been adequately treated? In the case of chlamydia, it's recommended that for pregnant women, repeat testing should be conducted 3 weeks after the completion of recommended therapy. For non-pregnant women, test of cure is not recommended unless compliance is in question, if symptoms persist, or reinfection is suspected. Repeat testing is recommended 3 to 4 months after treatment, especially adolescents, due to high prevalence of repeated infection. Furthermore, it is recommended to repeat screening at the next healthcare visits. The use of chlamydial NAAT testing at less than 3 weeks after completion of therapy is not recommended because false positive results might occur due to the continued presence of non-viable organisms. Persons who are diagnosed with chlamydia should be tested for other STDs, especially HIV, gonorrhea, and syphilis. The next sexually transmitted infection that we'll be discussing is gonorrhea. Similar to the first graphic, this graphic demonstrates prevalence of gonorrhea by state in the United States and in outlying areas from 2017. In 2017, 555,608 cases of gonorrhea were reported in the United States, which was an increase from 2016 reporting. In 2017, the gonorrhea rate was 171.9 cases per 100,000 people, an increase of 15.1% from the previous year. Gonorrhea is a gram-negative diplococci. It is spread through contact with mucous membranes, such as with sexual activity, and the most common sites of infection are with the urethra and the endocervical canal, similar to how we saw with chlamydia. The incubation period is a little shorter, 1 to 14 days, and it is the second most commonly reported communicable disease. Complications of gonorrheal infections include epididymitis in men, prostatitis in men, and then for females, pelvic inflammatory disease, which, similar to chlamydia, can lead to infertility and other reproductive complications. The rates of male to female transition are 50 to 70% per incidence of vaginal intercourse. Most men who have gonorrheal infections have symptoms. However, up to 50% of women may remain asymptomatic. Symptoms may present 2 to 10 days after exposure and are typically represented by dysuria, discharge, urinary frequency, abdominal pain, and breakthrough bleeding. As such, it is important to distinguish between UTIs as well as chlamydial infections. If left untreated, it can lead to long-term health consequences, as stated previously. Frequently, there is a co-infection with chlamydia, and patients should always be treated with for both gonorrhea and chlamydia, as they present very similarly. The CDC screening recommendations are the same as that for chlamydia. Uncomplicated gonorrheal infections. The drug of choice is ceftriaxone 500 mg intramuscularly by 1. If the patient is greater than 150 kilograms, the dose is increased to 1 gram IM by 1 dose. Alternatives include cefixime or other single-dose injectable cephalosporin regimens. Patients should always be treated for chlamydial infections with doxycycline. If patients have a cephalosporin allergy, you may use IM gentamicin plus 2 grams of azithromycin by 1 dose. Expedited partner therapy includes 800 milligrams oral cefixime plus doxycycline for a 7-day course. Ceftriaxone cures approximately 98 to 99% of uncomplicated urogenital and anorectal infections. Because of trends in antimicrobial resistance, CDC previously recommended combination therapy for gonorrhea with ceftriaxone plus either azithromycin or doxycycline, regardless of chlamydial co-infection status. However, due to the potential harms on the microbiome and other pathogens, this strategy is no longer recommended. So whenever possible, it is best to be able to distinguish between the two infections. However, if that information is unavailable, continue to treat for both infections concurrently. One thing that's a little bit different about gonorrheal infections is that there is a test of cure 7 to 14 days after treatment. For any person with a pharyngeal gonorrhea infection treated with an alternative regimen, symptoms that persist after treatment with ceftriaxone or azithromycin use only. Otherwise, men and women should repeat testing at 3 months after treatment. Similarly, collect sexual partner history for the last 60 days and abstain from unprotected sex for 7 days. We've listed pelvic inflammatory disease as a complication of both gonorrhea and chlamydial infections. Now we'll talk specifically more about its management.
So we've discussed how pelvic inflammatory disease, or PID, this slide presents some of the PID treatment options.
Or long-term
ceftriaxone plus doxycycline. With this slide offers a little background about what PID is. The ceftriaxone, we'll talk about doxycycline, most commonly caused by tracts, treponema. So continuing on the common theme, we're providing all requires some of the incidents in the U.S. primary syphilis may involve below that is the alternative separated by treatment. The incubation time is around 2 years. Overall, syphilis has 4 different stages of other vaginal latent syphilis phase. Excited syphilis, most infections are no longer starting for your incubation time now entirely learning to tertiary syphilis. This slide presents we'll talk about secondary stage. We'll discuss pelvic continuing on the primary this slide overall most involving the primary symptoms incubation time patient should talk about treponetic However,